This is a short talk about talking, about death and dying. Now, one of the unusual and special aspects of being a doctor is we have to deal with death or the possibility of death very often. If you think about people who are not doctors, unless they're soldiers in a battle, they do not have to deal with this problem as often as we do. And most people only encounter death a few times during their life. Now, we all have a very deep fear of death and dying. It's difficult to think about, let alone talk about. There was a famous quotation by the French writer La Rochefoucauld, who said, no man, you should say women as well, in the modern day and age, nobody can look at either the sun or death in the face. It is very difficult. But as doctors, we have to try. This, of course, is a famous painting by the Flemish artist Bruegel called The Triumph of Death, which shows people dying in all manner of ways. I remember it from when I was a young child, and I was terribly frightened by it at the age of 8 or 9. So we often have to talk about it, but in different circumstances. We may have to give a deadly diagnosis to a patient and say you have a disease which may kill you. We might even have to say which will kill you. We may have to care for a patient who is dying. And equally importantly, we have to deal and comfort the family of somebody who is dying or who has died. And in my opinion, after 40 years of medical practice, I think it's one of the most difficult things we have to do. Complicated technical brain surgery is much easier, believe me. And the fact of the matter is many doctors run away from this problem and do not talk or do not try to talk well or compassionately to patients and their families in these circumstances. I may be wrong, but my impression in Ukraine, having been working in Ukraine now for almost 30 years, is that many Ukrainian doctors do not deal with this problem very well. And that is partly a deep cultural problem. It reflects patience, but it also reflects the Soviet legacy, which is still there. That doctors are in a position of dictators rather than people there to provide a service and kindness to patients. Now, there are many reasons why we fear death and dying. Some of it, I think, is simply built into our brains and is just automatic. But we fear pain and suffering. We fear the loss of dignity and autonomy, which dying often involves. And many of us have regrets about the past and look back on our lives and are full of guilt or anxiety or regrets. And there is this deep sense of the loss of a future without going into well, I will a bit. And of course, there's the other question, does religious faith help? If you have religious faith, you believe, you hope for heaven. But at the same time, strictly speaking, you should fear hell as well. So believing in an afterlife is not necessarily helpful, although in modern times, some research has been done suggesting that people with deep religious faith perhaps suffer a little bit less than those without it. Now, talking about this question of loss of a future, this is a bit of slightly comical philosophy for you. There is a creature called a sea squirt, which lives in the sea. And as in many primitive organisms, it has a larval stage and then an adult stage, just as butterflies are caterpillars that then become beautiful caterpillars. Now, in the larval stage, the sea squirt has a notochord. You can just see it here, which is in evolutionary terms a very simple nervous system. But in its adult stage, the sea squirt, which when it's a larva, is swimming around to catch its food, in its adult stage, it becomes like a limpet and attaches itself to a nearby rock and no longer moves. And what happens? It reabsorbs its notochord. It no longer has a brain. And there is a lot of evolutionary theory suggesting why creatures on planet Earth developed brains. Is there a way of predicting the future? Because to move, you need to predict the future. You need to know what is going to happen. You need a model of the world in your brain. And perhaps it is almost for this reason, the thought of no longer having a future is terrifying and deeply disturbing, even though in a sense it's not rational, because the future has not yet happened. But those are the various reasons, I think, why we, all of us, fear death and dying, both as patients and as doctors having to talk about it. And what makes the problem so difficult, and what even more difficult, is that patients and their families will never tell you whether you have spoken well or badly to them. So learning is very difficult. All of us, we learn by doing something, getting criticized or seeing a bad result, and then doing better next time. But when our patients die, they don't bring us up from heaven and tell us whether we did it well or badly, and usually they disappear completely out of our lives. So we get no feedback, and again, the families usually are very reluctant to comment or criticize. So I don't know how well I did it over the many years I practiced medicine. And all I can offer you are a few simple observations, reinforced by the fact within the last few months, I've been diagnosed with cancer myself, with advanced prostate cancer, which may be curable, but may not. And over the last few months, I've had to see doctors and nurses and be in hospital, and also come to terms with my own mortality, which, given I'm 71 years old, is not that special. We all have to die sooner or later. And 71 is a good age to have reached. Nevertheless, it's been a painful experience and is not yet complete, but I hope I will live a bit longer. So dealing in the circumstances when we have to tell somebody they have a disease which might kill them, this is for the first time. Sometimes we see a patient, we know they are totally untreatable, but usually there's some treatment that can be offered. So we're not saying immediately you're going to die, but we have to raise the possibility that this might be their final illness. Now, the first thing to understand is patients and their families will only hear a very, very small part of what you say to them. They're so overwhelmed, they're so anxious, they're so confused, they will not be able to understand or take in a long lecture. And again, my own personal experience, when I met my oncologist for the first time, I was so anxious and confused. I missed half of what he said, and I think I misunderstood a lot of what he said. And of me as a practicing doctor, having spent my life having to have such conversations with patients myself, if I as a patient found it very hard to deal with, I'm sure all of us as patients will have this problem. So you will need more than one conversation. You can't just speak once and then it's finished. You need to speak simply and clearly and take your time. And of course, we never know what will happen exactly to an individual patient. The first question any patient with a diagnosis of a disease like cancer, and there are many other bad diseases, of course, is how long have I got to live? And of course, as a doctor, you don't know, because we deal in percentages. We could say, well, if I had 100 people like you, 70 would be dead within 5 years, which are the statistics that apply to me. But I don't know if you're one of the unlucky 70% or one of the lucky 30%. So you'll need to convey such emotionally terrifying and complicated information, you need to say as little as possible, particularly first time around. And you'll need to talk more than once, obviously. And as I said, we don't know exactly what will happen to the one particular patient. And it's quite difficult explaining that. As doctors, we think in terms of percentages. As patients, we think in terms of me. I want to know what happens to me, not what happens to 100 people. And the difficulty underlying this is you must never lie to patients. It never works in the long run, even if in the immediate moment, it makes the conversation easier. But you must never take away all hope, even hope to live for a few more days. Even people dying in a hospice will hope that maybe tomorrow will be a reasonable day. They may see some flowers or see their family. We all need hope. Only at the very end, when you're actually finally dying, perhaps, do we abandon hope? Do we abandon this deep, evolutionary, deep wish to go on living forever and this deep fear of actually dying? That's a very good friend of mine who was a very world-famous potter. That's one of his pots there. He potted, for those who are interested in ceramics and the Japanese Hamada Anglo-English tradition. And last year, his wife rang me up to say there were problems with him, and I helped organize a brain scan which shows this, which is a fatal, highly malignant brain tumor. And my friend Phil is now dead. And when I saw that scan, because these are tumors I dealt with frequently in my work, I retired, of course, from working in England 2 years ago. I knew he would be dead within a matter of months. And I felt obliged I had to discuss that with him because he was a very close friend. And he and his wife were looking to me for help and guidance. And I told him, I said, you will die from this. And I told him what I told most of my own patients. I was a bit more optimistic. I said, well, if you're unusually lucky, you might be alive in several years' time, but it's very unlikely. And so we discussed that. Now, in fact, we know technically that radiation treatment for these tumors makes no difference. It's been looked at, there have been trials and studies, but it's still orthodox practice to give radiation treatment. And the reason for that really is it's so difficult to say there's nothing we can do. And I could not bring myself to tell Phil it's a waste of time having radiotherapy. So we had to go a long distance to a radiation hospital, had it for several weeks, didn't help. And it was in a sense a waste of what little time he had left. But what I found interesting was that when I was speaking to him as a close personal friend, I couldn't bring myself to be absolutely honest with him. But I suppose I gave him some hope. And in fact, with tumors like this, for what it's worth, it's a very easy way of dying. You become confused, you don't really understand what's going on, and you don't suffer. The suffering is entirely for the family. If you look at the books about death and dying, you'll see that it's usually said we go through stages of grief. Grief when we know our own life is coming to an end, or grief when somebody we love dies. And they're described as denial, when you initially deny this is happening. I did that. I couldn't believe I had severe cancer to begin with. You become angry, and I became angry as well. And then you start bargaining and trying, well, if I do this or do that, maybe I'll be all right. Many people become depressed, and then with luck, you will end up accepting it to some extent. Now, we all go through these. You don't want to be too rigid about these stages. Different people go through them to a different degree. Some people become stuck in depression. You'll see that as doctors. And if somebody, when they've lost their husband or wife, becomes very depressed for a long time, you will usually discover, if you look, where there was a problem with the relationship or something like that. The healthy reaction to bereavement, as we call it in English, losing somebody you love, is eventually to be reconciled to it and to carry on with your own life. But you never reach that quickly. It is always a process of months. And you need to understand that when seeing people who have been bereaved. I think there are a few simple rules about talking to patients and their families when you have these very difficult conversations. You should always sit down and never break bad news, as we call it in English, standing up. It is unfriendly, it is intimidating. And also, if you're standing up, it will encourage you to be detached and unhelpful and unkind. So sit down, and you should never appear to be in a hurry. What patients want as much as technical information is respect and sympathy. Obviously, the problem we have is, as doctors, we mustn't be too sympathetic. Patients don't want us to break down in tears. We don't like that. But at the same time, we do want to feel the doctor cares for us, because we know the best guarantee we will be looked after well is if the doctor cares for us. Now, if you don't care for your patients, well, you shouldn't be a doctor. And if you don't, some doctors don't care for their patients, well, this sort of talk is wasted on you. It's always a good idea to have somebody else in the room with you, so that there's some kind of record of what was said, some kind of witness. And I think it helps. And as I said earlier, you should speak slowly in simple sentences, avoid talking in lots of complicated medical language. Only doctors as patients will understand that. And even then, I couldn't really understand what I was being told, because I'm not a urologist. I don't know about prostate cancer. And a very important point, which is actually very difficult, is to tolerate silence. When you have to break bad news to people, often the news is so shattering, actually there's nothing to say, or very little to say. I learned this lesson a long time ago when I was in the hospital in London, the Children's Hospital, where it was the only, this is now 40 years ago, it was the only hospital with a brain scanner. And the children were diagnosed in the, they have symptoms of a brain tumor. And they'd come to the hospital for a brain scan. And I was the most senior or junior doctor. I wasn't a consultant or a professor. And it was left to me to break the bad news to the parents. Now, it so happened my own son had a brain tumor when he was a baby, and we were lucky he survived. So I had some experience of what it was like to be a parent of a child with a brain tumor. And of course, it's such a shattering diagnosis. I learned very quickly. That was more or less all I could say. I'm terribly sorry your child has a brain tumor. And then you got to sit there and say nothing and wait for it to sink in. And the parents or the patients or their families may or may not manage to ask you questions. Usually they won't. But you shouldn't, if there's a silence, you shouldn't either rush out of the room, nor should you try to fill it by talking and talking and talking. You have to take your time. And with terrible news like this, often the best and kindest thing you can do is to be sitting down, saying nothing. Maybe, yes, you don't wait forever saying nothing, but don't be in a hurry to fill the painful, frightening silence with lots of talk. And you must give patients and their families time to ask questions. Usually, they only think of the questions after they've left the room. This is a standard truth, because we're always frightened and intimidated by doctors, and we're frightened of the truth as well. And we don't always want to really hear it, but it takes time to accept we should hear it. Occasionally, you'll find patients who are, or their families who are in denial, who simply will not accept what you're telling them. If that happens, you shouldn't challenge it. You shouldn't, if that's what suits them, fine. Don't argue with them about it. Denial, in one way, is a very good way of coping in the short term with a terrible problem. But there's no point arguing with it. All you do is gently question it. Another important point, not on the slide, is certainly in England, it may be different in Ukraine, you should always try to make sure the family and the patient know the same truth. I worked in some countries, so for instance, as in Nepal, in the Himalayas, and also in England a long time ago, where the family were told the truth, your father's going to die within the next few months. And the patient would say, don't worry, old chap, things are going to be all right. But if you create a difference in knowledge between the patient and the family, This is very bad, I think, because it makes it very difficult. The family can't then have an open conversation with the person they love. Having said that, you will perhaps, especially in Ukraine, you will have families who say, you mustn't tell them they're dying, you mustn't tell them. But that really reflects their own fear and the fact they are terrified of having to actually talk to the person they love about the fact they're going to die. So you need to try to persuade the family, if they tell you that on the whole it's better if you talk to them together and the patient and the family know the same truth. But sometimes it'll be impossible. And then a very basic rule for all doctors, listen to patients. You are young people. You have no idea, believe me, what it's like to have a fatal illness. I'm hoping mine won't be fatal, but it may be. So don't write me off yet. The only way you can learn what patients are going through, and so many of your patients will be old, most of them will be older than you, is by listening to them. They will educate you. They will inform you what it's like to be in their position. If you don't listen to them, you may be technically a satisfactory doctor, but you'll be a very second-rate doctor when it comes to the more humane, humanitarian aspect of the work, which is a very important part of the work, really, is what we as patients want. You know, we want to be, as patients, we want to be treated kindly and with compassion. Read books. There are lots of good books. The one on the left is written quite a long time ago. It was really the first book written about death and dying by Elizabeth Kubler-Ross, who was an Austrian-American physician. On the right is a book written by a very good friend of mine, which is being translated into Ukrainian. She's a palliative care doctor, and she writes about her work in a hospice. And there are, I think, 1 or 2 hospices in Ukraine, but it's not an established network in the way it is to some extent in other countries, and particularly in England, where the so-called hospice movement started. And what's beautiful about Rachel's book is it shows that dying doesn't always have to be awful. You know, if the family and patient understand and are well cared for, it needn't be terrible. And the fact of the matter is, we all have to die one day. By my age, it's no big deal. Obviously, the death of children, the death of young people is terrible and quite different.